So welcome back to the FKB Physio Podcast. This is the first episode I've done in a really long time because I've been working on building the business, and in line with that I actually have another member of FKB Physio on the podcast. So this is Jaslynn. So what we want to talk about today is basically what we love about physio and what's drawn us to the profession, and a few kind of tips around how to manage pain and injury in the gym. So we'll talk about our own experiences as well as how we might manage patients in our classes. So the first thing I wanted to talk about is, after reading your blog post, I saw that you realised that you wanted to be a physio after you saw us meaning physios, working in an outpatient department. Mm-hmm. So what about it did you love so much?
Yeah, so I think originally I was just shadowing at a hospital in Singapore, and the first couple of days I was just in like inpatient side of it, and I was just wanting to get some exposure into like what physiotherapists do, and the first couple of days I was doing inpatient. I was like, oh, I'm not sure how to do this because in Singapore at least I think it's quite like a top-down approach. Like the doctors usually kind of tell you what the diagnosis is, and then you kind of get told what to prescribe. So usually it's just like mobility, sometimes you get like incentive spirometry, that kind of thing.
Oh yeah.
And it wasn't really what I thought. It didn't really appeal to me.
Mm-hmm.
And then the last couple of days they're like, oh, you can like go shadow the mask outpatient department, and I was like, okay, cool. And then I went there, and I think the first patient that came in and they started talking, I was just like, oh wow, this is quite cool. Like,
yeah.
I can see myself doing this for the rest of my life. So I was like, yeah, okay, I think this is what I want to do, and then I just ended up pursuing it. Yeah.
Yeah, and so is it what in particular did you like about it, outpatient physio?
I think because it was very like problem solving, and they had quite a bit of autonomy, I guess. Like the patient came in and they were like, oh, like this is the problem I have, and then we did this in last session, but then this worked and that didn't work, and it was very interesting in that sense. It was like very problem solving, and it was like the physio was in charge of like
totally
the care, and I thought that was very cool because like they had like more autonomy, I guess, and like more say over how to manage the condition. So then I thought, wow, this is like pretty cool. Like you get to solve problems and you make a difference in somebody's life. So
yeah, and I reckon that's what I love about it too, the problem solving. And then I think the thing I really like is that we spend so much time with them, and so you really get to know them really well.
Yeah.
And I suppose exactly what you said about the top down approach. I feel like in some other countries, I worked in the Middle East for a bit, and I think it was a bit similar in that the doctors would dictate what you do, and then you just kind of do various treatments that the doctors had said. But I much prefer it in Australia, where we actually can diagnose and figure it out and kind of like work with someone to get better. Yeah. So now that you're working in the profession, has it been what you expected?
I think it took a while for me to find a place that I was comfortable in. I think like because I've chosen to work in private practice, like I don't really enjoy like the hospital structure and type of work. Like I think I have friends that do it and they love it, and I think it's really cool, but I don't think it was for me. And then in private practice, I think you have to kind of figure out what exactly you want out of the job, I guess. And I think now I finally found like FKB Physio has been pretty good, because I think like it gives you because the thing with private practice is that it's really hard to get people to keep coming back in because of like the cost and like stuff, and like it's hard to get that buy-in, I guess. But like here I feel like because people come in and there's a sense of progression, and you see them regularly enough that you can give them individualized care, but it's not ridiculously expensive.
Totally.
But you can still make a difference, and then you know their history because they stay with you, and then you can kind of progress, modify, and like I think that's cool. I think that's what I kind of really wanted, was to be able to see that progression. And it was very cool because you obviously see like middle-aged or like older populations lifting relatively heavy.
Yep.
And that makes it very like rewarding.
Yeah.
Because you're keeping them healthy, and then during the classes people will tell me that like, oh, like I could do this. They basically do a single leg deadlift to pick something off the ground, which they wouldn't have been able to do before joining the classes, and they're like, oh, I've got to thank Francis for this and stuff. So it was quite cool, like, because I think in other settings, I find that it's hard to progress to the point, like that point, because
Totally.
you kind of lose people along the way.
Yeah.
It's hard to retain people. But being able to like slowly, progressively improve their tolerance and their ability is cool.
Yeah, I think what I found over the years of being private practice physio was exactly what you said. As soon as someone's pain is gone, which might be pretty quick, then they've come because they want to get rid of their pain, and then that's it, it's gone. And often I'll think, oh, but you haven't actually like got you back. I haven't done I haven't finished what I think you might need. But exactly what you said, it's very hard to kind of convince someone to stay until that point. And then I also found that, especially if it was something that you knew it was going to go for ages, like a tendon problem or something, I'm thinking, like, I love exercise, but I don't do physio rehab at home. Like, I will not do it, even though I know I have to, I won't. But I'll do it if it's in my gym program.
Yeah.
And if I have to go to the gym and do it, and because I like going to the gym, it's easy for me. But I just found that you'd give people exercises and it was too difficult for them to do them at home, which I understand.
Yeah.
And so then it just wasn't really enough. But if you do these classes, I found that it meant people like want to come, and then you can make sure they're definitely doing the exercises, and then you can have this like up to date. You just keep, you know where they're at all the time. And I guess what I like about ours is that they're actually like in the prevention space, and so then because you have people that are there for like bone health maintenance, they might get to something that crops up during that time, and we already have this really long-term knowledge of them. And I really like it. And so I didn't know it would be like this when I made it, but like I love what it has become. And yes, I think it is a place for physio to like thrive, because the profession seems to have like a problem with turnover and stuff. And so I definitely wanted to make it so we could like keep physios in the profession in a way that's good and help
sustainable.
Yes, and like promote quality physio in like the wider society, because I feel like often we get a bit of a bad name. And so I think this is a way that people could go, okay, but there's this other type of physio and it's like this and it's different. So is physio in Singapore really different to Australia?
I can only say about what I've experienced. So like it was just a hospital, and then during COVID I actually went back to Singapore because the borders were closing and all that. So I worked as a receptionist in a private practice physio clinic. I would say, I think in general, physiotherapy sessions are longer there. I feel like there's actually a bit better like quality care. Or at least the physios that I worked with, like they were really good. So they like really tried to figure out what was going on, and then really spent a lot of time treating and like strengthening and stuff like that. But I'm not sure whether currently they do anything like this, like classes.
Okay, yeah. Is there ex-phys there?
There is ex-phys, but I think it's not as prominent as Australia. Yeah, I think that is still a very like emerging role. Yeah, but like I think mostly the physiotherapists would do that. I think there's exercise science, because my cousin's husband, so my cousin-in-law, is pretty sure he studied exercise science, and he's working at one of the hospitals, and I actually shadowed, I did shadow him before I decided to become a physiotherapist, and it was actually quite cool because he does like classes and stuff
I think I guess I've taught group fitness since I was 17, so I guess I've always loved group fitness. And then when I started in physio jobs, it would be Pilates. And then when I lived in the Middle East, I was able to kind of like set up my own thing within a gym there, and I started off these light exercise classes, but that was like when my transformation occurred, that I realized that I wanted to do strength training with the clients, because it seemed actually probably the best option. So I can see it's like been this consistent. I think physios love group fitness. They always do Pilates classes. It's like a common thing, but I guess they're doing more strength training is a bit different. Because I worked in England for 2 years, I just think it really coloured my practice, because over there on the NHS people don't have to pay at all. And that had good and bad sides, in that like the exact opposite to a private practice in Australia, where the manager might say, try to get the person to come back all the time. Well, even if they might not need it. In the UK it was like, the government's paying, we're overrun, can you try not to see the person many times? But I actually got to work in this specialist musculoskeletal hospital where it wasn't like that at all. It was like people were on big waiting lists to get in there. Like it was really, it was like a really good hospital.
Yeah.
And people would travel for ages to get there. And so I actually thought it was really good. It was really good. But it was very much like you have to do the thing that is most likely to help this person the most. You've only got half an hour with them, and they've been waiting 5 months for this appointment. And so it really just pushed it into the like exercise, lifestyle stuff.
Yeah.
But it was almost like the system almost created that too, because the person had to wait so long.
Yeah.
That like the pain became chronic because they were waiting.
Yeah.
And so it was this interesting thing of, it was so different to private practice in Australia because you'd be almost exclusively seeing chronic conditions.
Yeah.
That it had so little hands-on and so much exercise. It was like just useful to see that, because it's not exactly transferable to here, because you see people on day one post-injury here. Whereas there they were all chronic, but it was good to have that to go, hey, this is this other thing.
Yeah.
And also like the system over there seemed to kind of fund you to not be at work more than us, which again, good and bad in that I don't think it's fair someone should go back to work when they're in pain and they can't. But I also know the research shows that like trying to just get back to normal stuff as early as possible really helps. Like trying to make your life as normal as possible so the injury hasn't taken over your life.
Yeah.
And there, at least where I worked, because they kind of were able to not work while they were waiting for their appointment, the pain had a chance to take over everything.
Okay.
And so it was this weird thing where chronic pain seemed to be particularly problematic. Yeah. But at least it showed me this other side, and I worked in like a hypermobility team where people's shoulders would dislocate. And super interesting to me was that most people did have hypermobility, like Ehlers-Danlos, but most of the time their shoulder dislocations would coincide with stressful life events. And so the head physio, who's like guru physio lady who's written all these papers, she actually said, like, I've written all this stuff about the shoulder, but the actual, like, the hardest people that she's seeing, the biggest predictor of a pain flare is, like, psychosocial. And so that was really interesting, because I know when I was, newer in practice and it was, like, non-specific back pain and stuff, it's so hard to visualise. But this was, like, you could actually see their shoulder had dislocated and the person could kind of link it to, like, a stress period. It really just made me go, oh, my gosh, like, it's actually, you can see it. And I know it shouldn't matter, but it like, helped. But then when I came back to Australia, again, like I almost never see clients like that.
Interesting. I know where you can find that.
True.
Because the other clinics I've worked at, like,
I
think it depends on the location where you work and the population.
Definitely.
Because I worked at some places where like there are a lot of Medicare bulk bill, so like under EPC plans, and they don't have to pay a gap. And a lot of the times the people that will walk through the doors would be like people with a lot of psychosocial stuff going on. So like refugees or like non-English speaking backgrounds, or like people like pensioners. And they would have a lot of like socioeconomic stuff going on, and they would have a lot of chronic pain with a lot of neuro symptoms.
Oh god.
And it's interesting what you say about like hypermobility, because I think like there's like I kind of did see a trend of people with hypermobility like having like chronic pain, and then and usually they have like multiple other comorbidities. And then it all kind of just escalates into like an inflammatory response.
Totally. Yeah, it is interesting how, and I think that's really important, like when there's dogma around like certain physio. I reckon, say you're a specialist physio in Australia who sees purely private paying patients that seek you out to have your care at a high cost, you're likely to see this particular type of like highly motivated person that probably does have an injury that's more clear cut, like they ran a marathon and the knee hurt or whatever.
Or they have specialists that are taking control of like the rest of it.
Yeah, whereas if you work where in the NHS or like in a bulk billing kind of setting, you're likely to get the opposite, like the person is under the control of their own, like the pain is controlling them because they're not choosing to come to you, they have to come to you because they're in so much pain, and it's different. And it is interesting to, when I was thinking about where I've landed and how I practice, I'm like, oh, it's actually because you see all of that and then you kind of try to put it together with the types of patients we see. But I just thought, interesting to like the different countries and the different focuses.
I definitely think so. I think Australia is usually like one of the better, not better, but like it's one of the forefront of like the research in physiotherapy, and the way that where like the autonomy that physiotherapists here have, I think compared to rest some other countries, is pretty like quite good.
It's good, yeah. I guess like we've talked about before, the best thing would be though is if the Medicare maybe could fund it, because it is expensive, and I think that's a barrier.
Yeah, definitely.
So next thing I wanted to talk about was injuries in the gym, and so I think it's interesting I think people often go, oh, you guys are physios, like you would never get injured, which unfortunately for me is absolutely not true. Or they think like if you never get injured, but because you know how to manage it. Yeah. I feel like it's interesting to hear like a real world, like how do physios actually manage their own injuries in
I think physios are the worst at
yes,
managing
I think so as well.
Yeah.
You said in your blog post that you dislocated your shoulder.
Yeah. It was like, it's like the classic example of why like the physios are their worst own enemies. But it was during a jiu-jitsu competition, so I used to train jiu-jitsu quite a bit, and it was during a competition, like in the previous round, I felt like I think I probably did like a minor slap tear. I got my friend to do some tests on it, and I'm pretty sure it was like a labral tear or something like that. And then I just got the medic on site to tape it, because I was like, I think it'll be fine. I'll give it a go, and if it's fine, I'll just stop.
Yeah.
But it just went like in an awkward position, it just slipped out, and then it sucked. Like it was the most disgusting feeling, and I could still feel it like, but it's spontaneously reduced. But yeah, I think that's the problem with physiotherapists, is that we're like, oh yeah, I think it'll be fine, and then we just kind of like test the limits a little bit with our own body. Yeah. But I think nowadays I'm a bit more cautious when it comes to like, it just depends on what I think it is, and whether there'll be like lasting like extra, like whether it's a traumatic or like a non-traumatic kind of mechanism of injury. Yeah. So like if it's traumatic, I think there are guidelines that they're already established, so like either time or criteria specific guidelines that you have to follow. Definitely. So like if it's like an ACL, for example, or like a shoulder dislocation, you would need to immobilize for a certain period of time to allow the structures to heal, so there's no ongoing hypermobility. Yeah. And then like ACL, you have to meet certain like specific strengthening criteria. So I think for those it's very clear cut. Yeah. And like don't push, like you can push a little bit, and like obviously everybody has a bit of like differences in like their healing capacity and their tolerance. Yeah. So but then like by and large you still have to kind of stay within certain parameters. Totally. But I think if it's like more non-specific stuff, like the chronic pain kind of stuff, or like stuff that comes out of nowhere, like secondary to like a stressful major life event. Yeah. I feel like that kind of stuff, it's just your body being like, hey, like this is not within my capacity at the moment. Totally. And then in those cases, I'm not too conservative. Like, I would modify slightly and then like try to get back to where I was as quickly as possible. Yeah. Because there are no specific like parameters, like timelines or specific criteria. Yeah. So like that, I feel like if you feed too much into that, it sometimes can make it worse, because then you're too afraid to move it, then you end up like losing more strength, and then that kind of exacerbates the problem, and then you try to go back to where you were before that, and then the tissues are not used to it anymore, and then it just becomes this cycle, and then you think you're messed up, but no. Yeah. I think such a common thing. Yeah. So I think with those like non-specific type of presentations, or like the more niggle type of pains, it's more just like your body sending a bit of a signal that, hey, like this is not within my tolerable limits at the moment. Like and then the way I think about it is like, how can we find what's within the tolerable limits and then build it back up to where it was. Yeah. And I reckon that's really clear to me anyway, the way you described it, because I think that most people don't know the difference between like a traumatic incident and a pain that sort of has no trauma. And so like you said, like a dislocation, traumatic, an ACL rupture, traumatic, like rolling your ankle, traumatic. Whereas just like, say, your gluteal tendon hurting, or my shoulder hurts but nothing happened to it, it just started hurting. It's really different. And I guess like a lot of people think, oh, something hurts, therefore I should stop. But like you say, that's often actually not advisable, particularly if you completely stop and you stop heaps of things. Like trying to keep exercise or activity as close to normal as possible is often really helpful. So yeah, I think having that distinction is clear, but then it can be tricky when I'm just thinking of my own experience. Like I've never had like a rolled ankle or
I've never had a peripheral joint, like a knee or an ankle, acute injury.
Yeah.
And I think if I did, I'd be terrified. Like when I think about people trying to go back to, say, with your shoulder, I'd just be so
I was very
nervous.
terrified.
Okay, yeah.
But I think I was lucky because I talked to people who had dislocated their shoulder.
Oh, yeah.
And then also like I had some physio like friends
Yeah.
who had like specific, so they actually introduced me, like I was still a student at that time, they introduced me to like the therapy instability protocol thing, so then it's much easier once you've got like a guideline to follow.
Totally. And I think like that with patients as well, like trying to mimic, get it as close to what they normally would do like in a session, because I've noticed that often they're scared too, but if you can kind of make them do really hard stuff in the session, they're like, oh, actually it's not as scary. But I guess I've sort of never experienced it myself except with my back, because when I've heard it, it has been like a sudden, like it felt fine, it did like a snap feeling, and then it really hurt after.
Yeah.
Even though it wasn't a trauma, because it just happened from like bending over, it feels traumatic, and so like it's got that fear associated, and I think that really matters, because like the other stuff on me hurts, it sort of just like hurts.
Yeah.
And I'm like, oh, whatever, I don't really care how much it hurts, because it's like, well, it hurts and it might warm up. Yeah. And I feel I'm not scared of those pains, but I am scared of my back pain, because that moment, maybe like you're saying with your shoulder, like when that moment when it goes, it's so awful.
Yeah.
So I think it's important to know the difference when you're dealing with patients, and also with ourselves, to kind of go like different pains actually require different management. Yeah. But they almost never require total rest. Like when you dislocated your shoulder, I guess the shoulder you probably actually had to not do much with that, but you were doing everything
but
else.
I was like trying to keep the strength in the other like the other joints as well, and making sure it didn't like stiffen up. Yeah. And I was still trying to get like just activation of like the cuff and stuff to keep it. Yeah.
Did you find, did it have like big deficits in strength?
Massive, like
crazy. Hey,
it was very much, I think, pain inhibited. Like now I think I pretty much have the same strength or more, because my right side is now the one that's problematic.
Oh right,
yeah, but it had really massive deficits, especially in internal rotation. In like elevated positions. So then I had to strengthen that specifically, and then like in elevated positions, and then you kind of have to really find the deficits and then work in those ranges. But yeah, it was quite cool because I was very lucky. Like last year I had access to some like testing equipment, so then it could test your rate of force development and stuff, so then you can specifically train, like especially for sports.
Totally, for sports, really good.
Yeah, it was cool. Like you could see the deficit and then just train the deficits, and then it got better overall once you trained those deficits. Yeah,
and I definitely think when someone's had an injury, like I suppose it's really hard to predict injury, and it's hard to go like, oh, if you have a strength deficit there, you might get injured. But once someone has had an injury, I find then finding the deficits and addressing them is really key, and that's what I try and do it myself as well. And again, like I never know, like because I have a hip thing as well, like I never know if it's pain inhibited or if it's actually weaker, because when I go to do something, it really hurts, and so I can tell like the strength is way less, but I can't tell, is it truly less strong? But it sort of doesn't matter, because I'm like, well, if I'm trying to do strengthening on that leg, like I'm trying to do single leg exercises on it and force it to work, like that's what I'm doing. Like whether it's truly weak or not, it's not working in the way I need it to. And so the exercises I'm doing will help it too. And so the last thing is just when we have classes at the gym, obviously it does happen sometimes that people something hurts. I wouldn't say sustain an injury, like I really struggle to use that language, because I think a big barrier to people wanting to exercise is fear of injury. And so like I don't want to say, oh, it sometimes might happen that you get injured at the gym, but I also don't want to say, don't worry, if you're supervised by physios you definitely won't, because that's not true either. Sometimes things hurt. And so, but I found like, you know, with our clients, most of the time they'll just keep coming through that, which is great. I think that's really important, because I think often a narrative is like you need total rest. And so, when say if someone comes in with a pain in a class, like what do you do? Do you try to like get them to rest that body part, or do you try and work around it and still like load that body part in some way, or like how do you approach it?
I think it's great that people still come in, because they obviously like trust it, because you're a physiotherapist, like you know how to work around it. Most of the time people don't come in with like something acute, so I wouldn't rest it. I'll usually just modify an exercise within like a range that they can tolerate. Or drop the weights. Or find like maybe change the technique a little bit. Or like an angle a little bit, so that they still can do it. And it's still like using a certain muscle that would help support that particular joint, but it's just not irritable.
Yeah, and I think that can really help because, like, for so many different reasons, if you say you've hurt your shoulder, you might go to see an exercise person that's not like physio or rehab trained, and they might go, okay, cool, we'll just do legs today, we'll avoid the shoulder.
Yeah.
Whereas I think the fact that we go, hey, let's see if we can get your shoulder doing stuff that doesn't hurt, it's often really powerful because the patient will go, oh, I can't believe I can do that. Like, to us, we think, oh, it probably won't hurt to do this thing because we know what it is.
Yeah.
And they're like, wow, it doesn't hurt to do that. And it really makes them go, oh, my shoulder can't be that bad because I can do this and it doesn't hurt. And I think it probably has some effect as well on the brain going, like, if the brain's thinking danger, it's injured, if it can feel it doing something that doesn't hurt, the brain's more likely to go, oh, actually, like, consciously and subconsciously. Yeah, so I think it is really key, and I do think injuries tend to go for shorter if you do that sort of thing, because so much of the time it's like the secondary effects of having an injury that actually make it go for ages. Like, you know, you hold your arm like this for 3 weeks and then of course your arm hurts more when you try to move it out. Yeah,
and then you also have like secondary effects and stuff. It's interesting because like the brain is actually quite powerful, and when I dislocated my shoulder, like I thought it was like that was the worst injury I've ever sustained, I'm pretty sure.
Yeah.
So I thought it was like I was cooked. I thought I was like that was it. Like I thought I would never be the same.
Yeah.
And like if you told me 2.5 years ago that like I could have full function of my shoulder, I probably wouldn't have believed you. But then I was lucky, obviously I had the physiotherapist, and then also talking to people who had the injury and they managed to like rehab it to the point where they were still quite high, they were very high functioning. Yeah. And immediately after that, my shoulder felt a lot better.
Wow, so crazy. Yeah.
So it was like, it was a lot of fear, and like your brain's just like, I need to protect this at all costs, like it's bad, it needs to be protected, you can't move it. But then once your brain kind of accepts that like, oh, actually it might not be that bad. Yeah. This does not apply to everything, and you don't start like doing crazy things on injured parts, but like I think there is a component of like this like psychological part of it that like can exacerbate.
Yeah, it definitely does, and I think sometimes like that's easy to misconstrue, and that people go, oh, like it's in your head. Like that definitely happens, especially with back pain. Yeah. People will be like, oh, you know, when you hurt your back deadlifting, oh, it's just because you're scared of it, and I'm like, but also I also heard it. Yeah. Like the fear makes it the pain may take on like a bigger meaning, or it might mean that it feels bigger than it is. Yeah. Or my like catastrophizing as a result might go for longer or whatever. Yeah. But it's like it also may like something in my back was injured, and like your shoulder was injured. Yeah. I feel like it's so much easier when it's a peripheral joint. Like, hey, my shoulder went out and went back in. Yeah. No one can say that it's in your head. Yeah. But with back pain, they're more likely to go, oh, it's just your fear. But it's like, it's not that, but the fear does have a role. Yeah. Yeah, it's crazy.
I think the problem is that I think the problem is the some of the words used around like low back pain, especially like with like you know, like herniated disc and prolapsed disc and all that, and sometimes it's difficult when you've hurt something elsewhere that is like, oh, if you've hurt your back, like it's bad, like you need to do surgery, and then like there's a lot of fear around that. But then as physiotherapists, I think we are very lucky that like when people come in and we have the chance to like unpack it and be like, actually, you know, like a lot of it like reabsorbs within like 6 months or something like that, and then and then when you tell people that, and then you tell them that, you know, there are things that you can do, like strengthening around all the different, like the core, the other joints and all that kind of stuff, and then slowly getting back to where they want to be, then they're like, oh, there's a plan.
Yeah,
like,
totally.
There's a way forward. It's not all like surgery and doom and gloom. Yeah. And I think that helps people feel more reassured.
Yeah, but I think in contrast, like your experience of telling people about your shoulder and them telling you that they got back was good. Yeah. But I think in the general population, often the narrative around certain injuries is bad, especially back pain, and people will say, oh, like my friend hurt their back and like that was it, they had back pain forever, or they had to have surgery. And I think like anytime you hear that sort of thing, take it with huge grain of salt, because I suppose when I've met people, like the reason someone's back pain might have turned into a surgery or projected into be a lifelong problem, there'll be like a million really personal factors as to why that happened for that person. No two injuries are the same, so it's like two people might have the exact same diagnosis, they might have had the exact same imaging, and their outcome might be wildly different, and so there's so many factors that dictate whether someone's injury is going to become really, really chronic or not. Yeah. And so I think backs tend to have this like chronicity element to them that makes people freak out.
Yeah.
So I think, you know, if you do hurt your back or your neck, a place that people tend to be more worried about, just remember that I think people honestly think they're going to end up like not being able to walk and stuff.
Yeah, I think it's because it's close to the spine.
I think it's totally. There's like extreme minority.
Yeah.
And again, like keeping moving and keeping positive is really key.
Yeah.
And finding a good physio and working through it. Okay, great. Well, thanks, Jaslynn, and hopefully we'll do another podcast episode together soon.
Yeah.
Anything else you'd like to add?
No.
Okay, great. Well, yeah, thank you for talking to me about this stuff.